Hey, David.
Hey, Laura.
So last month, I took Jude for his final well visit at Danis Pediatrics.
Wait, he's already 18?
He is the big 18.
Oh my
So
gosh.
no more pediatrician visits. We got to graduate to the big world. And it was kind of nostalgic for me because we were filling out our final family well-being questionnaire like we do at each of our well visits. And I remembered Dr. Sally when we had Dr. Sally on as one of our first guests on the podcast.
Oh man, that was an awesome episode. It was one of our early ones, but it was so cool to hear her story and the legacy of Danis Pediatrics. And one of the most amazing programs I think that people are not aware of that Danis Pediatrics has is our Danis CARES program. And we talked about how much we wanted to take a deeper dive into that so that people could really understand what it is Danis CARES does for our patients and families.
Yeah, for sure. And I mean, all of Danis Pediatrics and their services are so unique, but Danis CARES, so CARES is an acronym that stands for Connection and Resource Equity Services. And it really kind of has become a hallmark of holistic care and how we provide care to families. And it's just become really the culture and how we do business over the last 5-7 years. And so oftentimes I take it for granted because it's just operationally who we are and how we provide general pediatrics to our patients. And I forget sometimes how unique and special it is, for sure.
And I'm so excited that we're getting to talk to a couple of her colleagues in Danis Pediatrics who were kind of the pioneers in getting Danis CARES off the ground from its beginning and are seeing how it's evolved. And then two of the primary leads who are the boots on the ground connecting those families with those resources that we have available. So we're going to have all four of them in here talking about the great work that they're providing every single day.
Yeah. And like I said, we sometimes take it for granted, but we're going to be talking with them about kind of how the program got started and the why, like what the need is, why we even do it this way in the first place, what all the elements of the program are, how we roll it out, how we connect these families to resources, and also get kind of their wish list for how they'd like to see the program grow in the future.
This is going to be an exciting and tangible, I think, episode for seeing where we can try and meet families where they are to provide care. And I probably ought to get up and make room because we're going to have a full house in here.
Yeah, you better. Let's go.
Here we go.
Well, welcome everybody to the Glennon Factor podcast. We're excited to have you guys on. I want to start, we know who you are, but I want to start with some introductions. So we'll just go around the room. Me and David won't introduce ourselves, but let's go around and just say who you are, what you do for Glennon, and how long you've been, I guess, with Glennon.
Okay, I can start. My name is Gene LaBarge. I'm a pediatrician, primary care pediatrician, also do some hospitalist medicine as well. I have been at Cardinal Glennon. I went to medical school here and started that in 1998. Finished that in 2003. Then I was a resident until 2006. I left and went out into private practice for a while, and now I've been back for 13 years.
You said that's no fun. Let's go back to Glennon.
That's right. Let's get back.
Okay.
Let's get back.
All right. Next.
I am Candace Eidelberg. I have been here for 2 years at Glennon. I started off in ED as a unit assistant. A year later, I came up to Danis Peds for the CARES coordinator, which is now a community health liaison.
That's a fancy title.
It really is.
You deserve it.
Yeah, thank you.
You're welcome.
Thank you. Yes.
Hello, my name is Fatima, and I'm the CARES office lead of the program, and I've been with Glennon for a little bit over a year.
I'm Josh Arthur. I am a general pediatrician like Gene, and I do some hospitalist. I also do some complex care. I've been here now 11 years at Cardinal Glennon. Before that, I was in the Navy for 13 years, and so when I got out, I came here.
I never knew that.
Yeah.
Really?
All over the world.
We learn something every single
That's
time
awesome.
we do this.
It's
love
called
it.
the Glennon Factor,
It sure
Laura.
is.
It's all about
I
education.
mean, yes.
So
Okay.
the topic of today we're going to cover is the Danis CARES program, which is awesome and fascinating. But I think we need to first get into what the program is to try and educate our audience and then talk about why we need something like that. So Dr. LaBarge, can you talk to us about our patient population and the things that make this program necessary to help out our community.
Sure, absolutely. The patient population that you're asking about is in reference to the patients at Danis Pediatrics, and Danis Pediatrics is urban primary care center. We consist of 2 locations. We take care of between 10 and 11,000 patients, somewhere close to 23,000 visits per year. So it's a busy place. We have lots of different providers, lots of different clinicians who work there, lots of learners, lots and lots of residents. Over 60 residents spend their primary care time there as well.
Wow.
The patients that we take care of tend to have higher social needs compared to average outpatient centers in other areas. So roughly 80% of our patient population lives in poverty. And we deal with all the associated concerns that come up with that.
So where did this whole concept of Danis CARES come from? Tell us the background of kind of how we used to provide care, and then there was a thing, and now we're kind of doing it a different way. So tell us the background of where this program came from.
So, and Josh, you can help me with this. It's kind of a long story, but I kind of feel like it all started with a cup of coffee, basically.
It's the best way to start anything is with a cup of coffee.
It is. And this goes back 10 or 11 years. And Dr. Ellen Barnage, she is a professor with the College of Public Health and Social Justice. She had done a lot of research into food insecurity. So basically that condition of not having access to appropriate food to meet basic needs. And her research really had been in rural areas of Missouri and not so much in our own community. And she was interested in creating a partnership, learning more about our patients, our families in the St. Louis area. And she wanted to partner up with people. And so what better place than Cardinal Glennon? So she reached out to us. And that was sort of the beginning of coming to a better understanding of our patients' needs, and then from there, even follow up on designing, implementing interventions.
What was Ellen's theory of like the way she studied and what she wanted to bring to Glennon and partner with Glennon? Like, what was her theory? If you do this, then this can happen. Like, what was the premise of her research?
At first, it was more understanding the community more so, and it's in starting with that, it was really interesting. And if you think about it, at that time, I think, and this is specifically for food insecurity, so not all other resource issues that we've broadened our scope to do our best to address. At that time. What was it? 1 out of 6, maybe 1 out of 5 family households in the United States were considered to be food insecure. And in St. Louis City, it was even higher than that. It was, I think, 1 out of 4, 25%, somewhere in that range. When Dr. Barnage and her public health students anonymously surveyed our patient families in the waiting rooms, I think they surveyed over 200 of them. 57% disclosed food insecurity.
That's a big jump.
More than half of an already high number. And it was pretty startling. We also, Ellen also really wanted to focus on understanding what are the barriers to addressing this, both on the clinician side, but also on the caregiver side. And so we did focus groups with families, and also we surveyed the entire Department of Pediatrics. We got maybe over 50%, which is pretty good to get over. You guys know this, over 50% of doctors responding to something. Yeah. Not great, but pretty good. And that survey response showed that people, clinicians, are very open to the notion that food insecurity has a significant impact on their patients. They're open to screening for it, but hardly anybody's doing it.
Mhm.
And the reasons disclosed were, what do we do if it's a positive? I don't know the resources, and all that sort of all the associated issues. And then on the caregiver side, there were a whole host of other things brought up, including concerns for judgment, and those sorts of things. Additionally, oh gosh, I'm drawing a blank on what were the other concerns. It was not considered to be a normal thing. Why would my doctor want to know about whether or not I have access to healthy foods?
Sure.
My doctor's supposed to help address the asthma, or whatever it may be. There were other concerns. I don't know if you remember.
The
Josh.
other ones, some families are worried about the custody of their children being at risk if they were to talk about social needs that they were having difficulty meeting. There were some families that were just uncomfortable talking about difficult concepts. Their child is in the room. And so potentially that would be, as we know, children are always listening. And if you're disclosing something to your doctor that's potentially stressful, the child will take that home with them. And that was something that we needed to be really delicate about as well.
So concerns from both sides on having transparency about social determinants of health, right? From both the physician and clinic side and the family side. But it sounds like the research showed that if you have this transparency and you have these connections, that can lead to better outcomes, right? As far as being able to access and health care and have better outcomes for kids. Yes?
Yeah, I think one other outcome that was interesting from the focus groups and the interviews of patients that we did is that patients, when asked questions about food insecurity, about 80% of them said that they were comfortable talking about that with their doctor, when we just asked all the patients in our clinic. But when we then stratified that same survey and just looked at patients who were food insecure, those patients were 3 to 4 times less likely to want to talk about it with their provider or their nurse, meaning families were comfortable talking about social concepts, but those who were having the most difficulty were the ones who were also going to have the most challenges with talking about it for all the reasons that we just disclosed. And so what that meant for our research team is that we couldn't just roll out an intervention that didn't recognize sort of the voice of the patient. How do they want to have this conversation with us? And then we also needed to incorporate the wisdom of the larger community and all the organizations we are connecting families to, because we could potentially come up with an intervention, but this was a very sensitive topic and we wanted to do it in a way that was diplomatic and thoughtful. And I think Dr. Barnage really brought that approach to our project, is making it community-centered, patient-centered, and never doing anything without making sure those who were serving were incorporated into the planning.
Was it like, wow, I had no idea this many people had this issue, or that this many people would divulge this issue, or that the people coming to us really have, was that surprising information to you, like the sheer volume? Or was it like, no, we kind of already knew, we just weren't doing anything about it?
I think it's both. I think, I can only speak for myself. I kind of already knew, but I was still stunned by the numbers, the sheer volume. When we eventually rolled out the intervention project, which was called PHASE, those referrals within our clinic fell under the social work umbrella in our order sets. And those numbers went up 2.5-fold once we rolled that out. And so it's just really stunning, the number of people who disclose needs, social needs, and who are open to receiving some support, that our colleagues can offer.
On one hand, I think the numbers are tragic in many ways. It means the children that we serve every day go home and often don't have a meal. You don't want to underplay that importance. And when you're just looking at a bunch of numbers, it's real people that we see every day. And so that should always be tragic. And it should make us always be thinking about what's the next and better intervention that we can do to make a difference. Interesting. This may just be my clinical style. I think the thing that was most, I don't know if surprising is the right word, but maybe the thing I didn't expect was how important asking families about social needs and actually being able to have conversations. I didn't really realize how much it would change the relationships I had with the families themselves. Because sure, for some families, it's possible they didn't want to disclose the things and they just said no on the screening form. But when a family said yes, they're already opening themselves up in a way that requires trust. And then when I accept that trust and then I say, wow, sounds like things have been really stressful. Tell me what that's been like. It allows this whole new avenue of relationship. And remember, I'm an outpatient pediatrician. I'm seeing these patients for years. I've been here 11 years and I'm seeing kids graduate from high schools that I saw, as elementary kids when they got here. And so now I'm able to have a very different conversation with those same families that I'm seeing for a decade about like, what is your life really like? What are the barriers to your child being healthy? And how can I be a part of it? I'm not going to promise that I can solve all the problems, but actually I'm a part of them, maybe in a way, or part of the solution in maybe a way that you wouldn't have expected. So for me, that's why when we got to the end of the first grant, I said, this is the type of relationship I've now had with my patients for 6 years. It can't end. We can't ask questions and not have answers. And so what is the next answer going to be? Here at Cardinal Glennon, we have the great resource of having the Cardinal Glennon Foundation. And what that allows us to do is be innovative and flexible when things like this happen, like a grant ends and we say, well, we need to do a next step. If you were to ask me then what it would look like today, I wouldn't have necessarily been able to tell you because things change. The types of programs we do need to be customized to the population we're serving and the resources around, and things are changing. And the Glennon Foundation gave us the funding during that transitional stage to say, what does the next step look like? And then create a robust program that eventually could become a part of the sort of ethos of Danis Pediatrics. And then eventually, like we are today, become funded by the hospital itself.
It's so awesome that you all were able to gather the data and figure out what some of the things were that you were seeing in clinic every single day to support solutions potentially. So the program has grown and evolved over the years. Can you tell us what the care team for Danis CARES looks like today? Who's a part of it? What everybody's roles are on the whole team?
Sure. So the Danis CARES team consists of 3 individuals, Jesse, Candace, and myself.
3.
Yeah, so
3 people.
For an entire
For
clinic.
what now?
That is
22,000 visits. Okay.
we are
All right.
a small
Y'all
but
working
very
hard.
mighty team.
Small
So
but
you
mighty.
all handle like what, 13,000 visits a piece?
Well, just this year alone, we've handled a little bit under 2,000 families that we've been able to directly interact with and help them, provide them resources, and genuinely witness their resiliency to the hardships that they go through. Candace can let you know that, again, she came from the ED, so these are ongoing social determinants of health that affect families throughout many different aspects of their lives. So we're really fortunate to be able to address it in a primary care setting.
So I'm a patient. I'm coming into Danis Pediatrics. I'm here for my 6-month shots. How is the team going to know that I have needs?
So they are given an assessment. Certain families are given assessments and they will fill it out yes or no if they need anything.
So just
and
like
I go
a
off
questionnaire that's part of their
visits.
Their visit? Oh, okay.
And whatever they say yes to, I go in and ask them. And I also ask other questions besides the ones that they answer yes to, because, sometimes they're not going to tell you everything. So I just get comfortable with them and he and ha ha. And I just build a little relationship with them with the time that I have with them. And they go in and tell me more than what they filled out on a piece of paper.
So for people who don't know about the piece of paper, I know about the piece of paper because my children come to Danis Pediatrics. So I've filled out the family well-being questionnaire, but tell our audience what is on that piece of paper. Like what types of things are we asking our
So the resources
families?
that we are asking is food insecurities, financial literacy, transportation, if you need assistance with housing, if you depressed, going through anything, postpartum for new moms, and anything else that they decided they want to talk about.
That's a lot of areas, but I mean, at the end of the day, you're trying to take care of the whole family. I think we heard Dr. Sally talk about that in a previous episode, talking about caring for the whole family. But so that's a lot of questions. Fatima, can you kind of get a little bit more specific and granular about, I mean, obviously Danis CARES can't solve and support every single need, but can you outline us some of the specifics that we can support a family with immediately, but then also some of the partnering resources that we have available that we can inform our families about?
Yes, absolutely. And that is a big part of our work on the Danis CARES team, is to contact organizations and understand what their support is. So when we give the resource to a family, it's something that we know is going to be sustainable. It's something that's going to address a need, but also eventually give them the opportunity to be self-sufficient and no longer need that resource. So for example, food, which is one of the most common ones, we actually offer meal kits at our clinic. We had a very successful food drive this year, and any family that marks yes to having food insecurity, we can offer them immediately a bag of food that they can leave with that day. Aside from that, we make sure to give them a list of local food pantries where we do contact them. We make sure that they are open, their hours of operation are still the same. If they have any eligibility requirements, we make sure to inform the families so they're not walking in somewhere expecting something that isn't going to deliver to their need. When it comes to transportation, we're lucky enough to have funding to be able to arrange transportation for families who do not have vehicles. Right now, it's the middle of winter. It's very cold. So even the idea of having someone stand at a bus stop with a newborn, it's just so much better for us to be able to offer that care of letting them know a lift is going to be at your home at this time. Please don't worry about that. We're just happy to see you.
One thing to just understand about the logistics of the screening is that there are multiple levels of intervention, even when you look at we call it the green sheet, but the family well-being questionnaire, it just happens to be green because we have to, it's a pediatric clinic.
Do you ever
Everything.
change up the color?
Oh, no,
it
would
be
be
pink for 2026.
No,
or
pink.
There is
no?
a pink sheet.
The pink is
that's
postpartum
different.
depression screening. Yellow is autism screening. Like,
Wow.
Paper
if you
companies,
changed it-
please continue to make green paper, pink
Yep.
paper, and yellow paper.
oh yeah,
Some of us might not be able to go to work the next day
no,
if we change
that
the
would be
colors.
right. That would be right. So when you look at that green sheet, there are actual questions that are not always intended for the Danis CARES program. If you go lower down, there's questions about firearm safety, where the clinician will typically provide a firearm lock. That isn't necessarily part of the scope of the Danis CARES program. However, because we all work together and we're a team, we're often sort of overlapping on different people's resource connections.
Is that kind of a partnership with the safety program? That
That's
Cardinal
with injury
Glennon also
prevention,
has?
yes. Yep, so that's where those come from. And every question on that questionnaire has been vetted over many years. When we started, I think it was 13 questions, and some questions have been added and some have been taken away based on the answers we get from patients and the resources that we have available. So as we were crafting the questions over the years, we always did it with the social worker in mind as well, with the recognition that the social worker in our clinic has a specific set of skills that might be well equipped for things like domestic violence or a patient who's suicidal. And so one of the conversations we had very early is, what is Danis CARES scope of practice? What is going to be the clinician's scope of practice? What is going to be the social worker scope of practice? And many other programs we have in the clinic. How do we make sure that we're communicating well and making sure the right provider goes to the right patient? And so that green sheet isn't just used by Danis CARES. It's really used by the whole team. But I would say probably Danis CARES is going to get 75% of it.
I have so many questions. My mind is just like spinning. Okay, but the next one. Okay, so kind of to layer on what your comment that you just made, what is the process? So, okay, I've completed my green sheet. Thank you very much. I turn it in to whoever, whether it's my resident or nurse or whatever. So they have it. Okay, so on my sheet, I have identified, let's see, I need some I have some food insecurity. I don't feel safe. I whatever. Who parses that out, so to speak, and says, okay, Fatima, you're going to take this, and let's call in the social worker for that. So how does the connection to the either immediate or external resource, what's the process after the green sheet is filled out?
Is it the team of three just splitting the questions up evenly? Or
Rock, paper, scissors.
Yes. So usually the doctor or resident will come in and let us know, give us a heads up about the patient. They'll let us know what is needed, only if they talked about it. But usually the patient will discuss the needs that are needed. And I will go in and I ask, and I welcome myself, and like I said, make them loose and comfortable, make them comfortable with me, and just talk about what's on this green sheet that they need assistance with. And sometimes they don't need it. Because it's a question like within the last 12 months. And they'll say, oh, maybe a couple of months ago I was okay. I'm good now, but now I'm okay. I just answered yes because it said within the last 12 months. So they are okay, but they still answer yes. But if they are in need or whatnot of any resources, I will let them know what is available. When it comes to food, we have meal kits. Some people accept them, some do not. And I also pass out the food resources that we do have available.
Oh, they're all of the areas that you all are trying to take care of the patient, the family, not just putting a Band-Aid on something, but trying to do long-term solutions. Like it's humbling, it's inspiring, it's all awesome. I know you all get to impact it and get to see this every day. I think we'd love to maybe hear some stories just to kind of give some tangible examples of some of the family situations that you have come through Danis CARES, where families are expressing need, building that trust, like you said, Dr. Arthur, and getting comfortable with you, Candace and Fatima, about letting you know that I do have a need. So can each of you take maybe a few minutes to share a couple of stories just to kind of give us an example of tangible experiences we're having in Danis CARES?
So my first year here, I met a mom and her daughter, and she was in need of housing and a job. At that time, she was living with someone, and things wasn't good. So I gave her the resources, and the next time her appointment come along, she's like, Candace, thank you. I'm like, huh? I got a job. I'm like, girl, where? So she's doing internship at a law firm. And I was like, okay, all right. I was like, what about housing? She was like, I'm working on it. I said, okay, all right. I'm like, you got this. We got this. You go get someone to stay. We working. We okay. You got a job. You go find a home. So I just saw her recently because I haven't seen her, going between both clinics. And I saw her one day right before I got off. And I was like, oh my goodness, there she go. I'm like, I'm so excited. I was like, how everything going? How you doing? And she's still at the law firm. And she has somewhere to stay for her and her daughter to call home. So just to hear those news and the resources that I've given her for housing and for employment, it's exciting to know that what I'm doing every day is impacting these family lives, and they are using the resources that we give them. So just to see her, because I've been talking about her lately, because I'm like, oh my goodness, I hope she's okay, because I haven't seen her. It's been over a year. And she was like, they look good. Everything is going well for her and her daughter. So it's a good thing. Yeah.
For sure.
Yeah.
Well, my story is a little more recent, but it's just a very common circumstance where a mom actually called our appointment line to let them know that she was not going to be able to come into the hospital for a bilirubin redraw. She had a newborn baby. It was about a week old, and she called the appointment line because she didn't have transportation there. Our PES staff who schedule our appointments reached out to me, and I was able to call mom and arrange a ride for her to come in. Not only was she really grateful about this, I was able to also help her with her next appointment for a weight check to make sure that the baby is growing and developing healthy within the first few weeks of their life. She was just a total sweetheart and was so grateful about the whole support we were able to offer her in the meantime that her insurance kicked in. Because, I mean, this is a newborn baby. You don't get health insurance the minute you come out of the womb, unfortunately. So it did take a few weeks for her to be able to have stable transportation. But every time I see her now, the baby's a few months old, she always mentions how grateful she was for those initial appointments and how we were able to get her to Cardinal Glennon.
That's amazing. I always like to say I'm usually the only one here who's not medically inclined. Laura, you've got your medical history. You all work in the hospital day in and day out. Can you, I don't know what a bilirubin draw is. I've heard of bilirubin with NICU and stuff, but can you kind of explain to us what the alternative, like what could that have meant for that child had we not been there to offer transportation for them to come in for that clinic visit?
Well,
Yeah.
two physicians.
Well,
No, Fatima, we want you to answer that.
that's right.
I studied social work.
Bilirubin is a molecular product found within a certain part of the body, the red blood cells of the body. And bilirubin naturally rises in the first few days after being born. And it's very common. And that's what leads to jaundice, or the yellowing of the skin. About 60% of all babies will have jaundice at some point, and it usually reaches its peak around day 4 or 5 and then naturally goes down. But there are a significant minority of patients who have a degree of jaundice or high bilirubin levels that are going up too quickly. And if it goes up too quickly and is untreated, then that can actually be dangerous to the certain aspects of the brain, can actually lead to long-term brain damage. So it's imperative that we track this, that we make sure it's not reaching a dangerous level, and that if it is going up too quickly, that we move forward with treatment. And treatment would require hospitalization.
So something as simple as just getting transportation for a patient family could help prevent future hospitalization. It's amazing.
How has being part of this program and doing this work, how does it impact each of you personally?
I can wake up every day knowing that I'm going to a place that I know I can make a change. I can make a difference in someone's life. Even if I do not have the resources that they need, I will give an encouragement word, give them hope that things will get better, which it will, and just take time. Be patient, and it will take time.
You've humanized them.
Yes.
And you've given them dignity.
Yes.
You know?
Personally, I find it incredibly humbling. I find each interaction that I have with these families very meaningful. I try to, similar to Candace's answer, I try to genuinely think that this work is very purposeful and meaningful to families that otherwise would go to maybe a clinic that wouldn't address any of these things, even though it is so prominent in their life, these barriers. So for me, it's just an honor really to try to give those people, even in that moment of the consult, that they're not alone and someone does care, that what they're going through matters and they matter. And again, we treat everyone that comes in through those doors with dignity that they deserve.
Yeah. Yeah.
The phrase, I see you,
Yes.
comes to mind, right?
Yes.
How about you two?
Well, I agree with humbling, very much so. It's pretty humbling to witness the power, the spirit of so many of our patient families, parents and caregivers and children, just really resourceful, resilient, and strong people. And it's been pretty humbling to witness that. And the other piece would be just the power of the connections that are made, that we make with our families. And it has truly direct impact on the things that we learned, that Josh and I learned in medical school, how to manage asthma and how to minimize the risk for iron deficiency, anemia, and all these sort of primary care pediatric sort of things. I firmly believe that these connections that we are able to make and foster and grow reduce the likelihood of those medical problems that we're really trying to focus on anyway.
Just to sort of piggyback on what Jean said, certainly building those types of relationships is very directly correlated to my own job satisfaction. I didn't, get into pediatrics or get into medicine to be a pure scientist. Science is interesting, but I did it because I want to use science in service of people. But then to take that even to another level, we're at a teaching hospital. So that means as I am using science in service of others, I am also role modeling that for 60 residents every year come through our clinic, and about 180 students come through our clinics. And so what we are role modeling to those students is that holistic medical care looks like this. We're going to ask questions that matter. We're going to ask about the environment that patients go back to. And some of those future physicians, the medical students, are going to do adult medicine. That's great too. The idea is that we are training the next generation of physicians to see the whole person when they take care of their patients, whether they're going to be surgeons, whether they're going to be primary care. And that, I think, is a really amazing part of this program.
I knew I liked you for a reason. Okay, last combined question, because I'm really good at that. Okay, how is Danis CARES as a program evolving? In other words, like you talked about all the iterations of the questionnaire, but like as a program, how's it evolving? And what is your magic wand wish list? Y'all come across a lot every day. And if you could see it continue to evolve in a positive direction, where do you want to see it go?
Well, my magic wand is to continue to have the support of all the different organizations that provide us so many of the essential items that we provide our families, from different hygiene kits that include essential things like toothpaste and deodorant that do cost quite a bit of money when you're buying it for multiple children in a large household, to menstrual supplies, to clothing, winter coats. My magic wand wish is to just continue receiving that support and expand it to additional organizations as well.
My magic wand, because I want to take over the world and help everybody that I come across. I just would like to get in contact with agencies that when a family is in need for utilities or rental assistance, just so they can have a direct contact instead of having to go through so many different avenues just to get to this one person to help assist them with their utilities or their rental assistance. So just get in contact with this one person that will link up with Danis CARES and say, call me, refer such and such to me, and I got them. So yeah, that's my magic wand.
Ease of access right there.
Mm-hmm.
It's awesome.
I think for me, I think of Danis CARES, it's truly a community intervention, and the heartbeat is community partnership. And community partnerships are hard to maintain just for practical considerations. Funding changes, staff change, and it's just hard to maintain those relationships over time. And Candace and Fatima do a great job. It's just not easy. And so if I had a magic wand, I would use it to really deepen the partnerships that we have, especially with the schools. There's so many different school districts that serve our patients, communicating with those teachers and principals and nurses. Educational outcomes are such important drivers of health. And that would be obviously a core community organization, but just improved communication with all of them to prevent us being in a silo. We see the patients once or twice per year on average, and then they go back into these other amazing community spaces that sometimes we don't communicate well with. And I would love to have that grow over time.
Nothing to add. You stole my part about,
Gotcha.
yeah.
You shouldn't have waited so long.
I know. So much for manners. No, I think the connections piece is just so critical. And I think it's important for us, and it makes it more manageable in my mind, for us to think about that. Danis Pediatrics is not at the center of that. We're just part of it. We're just a part of it, and we want to be as connected as possible to all the other community resources out there. And what I was going to come in on was schools, because that really is where our patients are most of the time.
Mm-hmm.
And so in really enriching those connections within schools to healthcare providers, I think would be really a great thing.
One thing I wanted to just mention, I talked a little about this earlier, just how much we appreciated the support of the Cardinal Glennon Foundation when we were sort of in this in-between time when we were creating Danis CARES. And actually, I should add that the foundation and its donors certainly helped with our funding, but it also helped us craft what Danis CARES would look like. Because when you put in a funding proposal, you have to think thoughtfully about how is this going to serve the mission of the hospital. And we learned a lot from the first iteration so that we can make sure that this fit perfectly into what Danis CARES and what Cardinal Glennon is all about. And over the past few years, I think we have been validated that this program has continued to grow. It's continued to get better, and it's continued to generate a lot of stories that people hear about at a lot of the, probably at the Glennon Gallup and other different opportunities that we have to share our stories. And so we just want to thank everybody that has supported us here at the hospital and in the foundation and among donors, because it really makes this vision of holistic and a holistic care for all families and children possible.
100%. I completely agree with you, Josh. It's not lost on the four of us that pretty much none of this happens without the support of the foundation. In particular, that period of time when our funding had run out, and we were trying to find ways to make this project sustainable, the foundation listened to us, and that is the difference. That's why we are doing what we're doing right now. And so as things continue to evolve, I'm just completely grateful that the foundation, all its donors, have supported us to the extent that we've received, and completely just humbled by all of it.
Well, I love that we have had time with you today. And I think that this program just so beautifully and perfectly aligns with Cardinal Glennon's mission.
Absolutely.
Two of our values, two of the, 5, 6, I don't know, that I feel like that really stand out about this are community and excellence. I feel like this program cultivates community partnerships, right? You're optimizing justice by doing everything you can for our underserved population. You really have built this amazing model of community in action, which ultimately helps our patients socially, medically, and all of that. And we're just proud to have you as part of this. We're proud to use this platform to further educate and inform people, and just be proud of the work that you do. And thank you.
Well, thank you
for being amazing.
Thank you.
We hope you enjoyed this episode of The Glennon Factor. Make sure you follow The Glennon Factor and leave us a review wherever you get your podcasts. Visit glennon.org if you would like to learn more about how you can support Cardinal Glennon kids. And while you're there, feel free to share any feedback or episode suggestions on our podcast page. The Glennon Factor is recorded and produced by SSM Health Cardinal Glennon Children's Foundation.